So it's my pleasure to introduce today's speaker, Dr. Idunn Morris. Idunn is a clinical academic at the University of Sydney and an intensive care specialist at the Nepean Hospital in Sydney. She trained across the UK, Australia, and Canada, and is currently completing her PhD at the University of Toronto under the supervision of doctors Iwan Golliger and Neil Ferguson, which focuses on diaphragm neurostimulation, assisted ventilation for lung and diaphragm protection. So Idunn, thank you very much for being here, and the floor is yours.
Thank you. Thanks so much, Andrea. Thank you for the invitation. So yeah, it's 10 p.m. here in Sydney, Australia. I'm part of a couple of grants from CIHR and ESICM, but don't have any other significant disclosures to mention. No conflicts of interest, a fair warning ahead of time that there will be some physiological equations and some physiology that might make some of you shudder, but as long as you're ready for that. Otherwise, yeah, no conflicts of interest, and certainly no funding for this talk. I just want to start by, I'm here in Sydney in Australia, and I want to just acknowledge the Aboriginal people of the land on which I'm on at the moment, which is the Diaphragm people, and pay my respects to the elders past and present. Now, the learning objectives for this talk, as I set out, was to explain and help people understand how physiology can inform the assessment of acute hypoxemic respiratory failure, understand and recap some of the really fundamental evidence base that I'm sure many of you will be pretty familiar with. This is an introductory talk, so I'm going to keep it fairly, on the core aspects of that. Maybe touch on some of the controversies in the management and maybe give you my personal perspective on that. And hopefully help you become familiar with some relevant ongoing clinical trials, particularly in the platform. Things that I will not talk about, because they have either been very well covered in previous webinars or they will be being covered in future webinars, is NIV and high flow. So I will skim over that. I will not be talking about indications for ECMO and ECMO management. This is going to be a physiology-based talk, and I'm not going to talk about biological phenotypes, and they're very important, and their targets and their therapies. So I will be particularly keeping away from that. There's another excellent talk already on that subject. And I think there's an upcoming talk from Irene about monitoring respiratory drive and effort. So I will talk a little bit about drive and effort, but I won't be talking about monitoring of that. So I just wanted to start this talk by making sure we were clear on a few definitions, because a few terms get used interchangeably. So hypoxemia being low oxygen in the blood, hypoxia is at a cellular level, and of course acute hypoxemic respiratory failure can cause both of these, and importantly can cause hypoxia, but not necessarily directly through hypoxemia. And I will touch on that particular aspect maybe a little bit towards the end of my talk. So hypoxia at a cellular level can be roughly divided into 4 groups, as I'm sure you all know. So there's hypoxemia. Next slide, sorry. Yeah, that's perfect. Okay, so in terms of hypoxia, this is your first, as I say, torture back from medical school or RT school, is the oxygen cascade. I find this helpful in terms of thinking about the areas where hypoxemia can occur. So roughly in my mind, I think of it in sort of another 4 blocks, which is there an issue with alveolar oxygen content? Is it a diffusion capacity issue? Is there a VQ mismatch issue? And then a category of a couple of other less common things I put together in the others section. Next slide. So this is a bit of a busy slide, isn't it? So to start with alveolar oxygen. So if the alveolar oxygen content is low, that is either due to a low partial pressure of inspired oxygen, which is unlikely unless you're practicing at altitude, or it's due to hypoventilation. The alveolar, this is your second bit of physiological torture, is the alveolar gas equation, which, if you remember, is which I outlined down there, but gives you at room air an alveolar partial pressure of oxygen at about 100 millimeters of mercury, and that's assuming a normal CO2 of 40 and a respiratory quotient of 0.8, which is fairly normal. You'll see if you increase the FiO2 to 100%, the alveolar oxygen pressure goes up to 663. If you back at room air again, if you double your PaCO2, so ventilations are inversely proportional to your PaCO2. So if you half your minute ventilation and double your CO2, your alveolar oxygen concentration will half. And if you were starving and you went from a respiratory quotient of 0.8 to 0.7, because you're mostly metabolizing fats, you'll see it didn't massively make a difference to your alveolar partial pressure of oxygen. So from this, we can calculate our AA gradient, so alveolar arterial gradient. And in health, that sits somewhere between 8 to 20, and that range basically increases as you get older. So in an issue with alveolar oxygenation, your AA gradient should be maintained. These patients will tend to have a CO2 that is lowish. So if you remember things that affect your a CO2 that will be highish, because things that affect your minute ventilation, your ventilatory drive, is predominantly going to be your hydrogen ion concentration, your peripheral and central chemoreceptors. Your peripheral chemoreceptors, the effect response to CO2 is modified by oxygen. So CO2, increased CO2 leads to increased hydrogen ions, will increase your respiratory drive. But if you are hypoxic, a lower level of CO2 will modify that. If we move on to the next slide, or might be, I think there's a little visual demonstration of that here. And I think this reminds me, it makes absolutely no sense to me at all that in patients with opioid PCAs, for example, where they were giving them a drug that suppresses their central nervous system, that where we give them supplemental oxygen so that they get respiratory depressant drug, and then we increase their oxygenation to even reduce further the sensitivities of their the peripheral chemoreceptors to that. So in summary, for alveolar oxygen issues for hypoxemia, the two main common things that I think of is a reduced respiratory drive, which is either due to a CNS issues or most commonly due to drugs. And the other thing would be reduced neuroventilatory efficiency. What I mean by that is either neuromuscular uncoupling, so you have some issue with respiratory muscle weakness, or it may be that you have such severely impaired mechanics that you're unable to generate normal tidal volumes, even though your respiratory muscles may not be profoundly weak. I'll go on to the next slide. That is a slightly oversimplification, and obviously there are lots of things along this journey that can further affect that, but they are really the two sort of main categories I think of in there. So we have, as we've already talked about, sedation and drugs that affect your respiratory center output. We have things that might affect neural signaling and neuromuscular transmission, and that includes things like your polyneuropathies you might get as part of critical illness, and then obviously other underlying diseases such as myasthenia gravis. The pH and calcium concentration intracellularly affects your excitation, contraction, coupling, which could comes in with some severe electrolyte disturbances. We've talked about muscle mass and function, but the performance of that is also impacted by your end expiratory lung volume and the length tension relationship, for example, of the diaphragm. We've also touched on severely impaired respiratory mechanics and how that might fail to transmit fairly normal respiratory muscle function into a tidal volume and a rate that generates adequate alveolar minute ventilation. Next slide. So we then move on to diffusion capacity, and the equation for you to think about here is the Fick's diffusion law, and this is here, and as you can see that the diffusion is dependent on area, the diffusion coefficient of the gas, the partial pressure gradient, and the thickness. And in practice, what that means for us is predominantly we're thinking about thickness issues. Technically, area could be, but as I'm sure many of you have looked after patients who've had a pneumonectomy, for example, and they're not walking around hypoxemic because there's so much slack in the system, you can actually lose quite a lot of area without becoming hypoxemic. So really it boils down to predominantly a thickness issue, which may be in terms of clinical things you see, like an exacerbation of someone who's got pulmonary fibrosis or acute interstitial pneumonitis. PJP would be one that I particularly think of in this category, less commonly diffuse alveolar hemorrhage. And of course, patients with ARDS do have some degree of diffusion capacity issue in terms of developing interstitial edema, then hyaline membrane formation, and then fibroproliferation. The image on the right is there to remind me to tell you that when we talk, so if you become hypoxemic, your respiratory center output, the threshold for the CO2 to increase your minute ventilation is lowered, so you're more likely to hyperventilate. If you hyperventilate, you drop your CO2, and using the alveolar gas equation, you'll see that your alveolar concentration of oxygen increases. So you may protect yourself in a sense from hypoxemia just by the fact that you're hyperventilating, even though you have a true issue with diffusion capacity. This graph nicely demonstrates, however, that as your minute ventilation increases, you will see that the first initial part of that is usually due to an increase in tidal volume. And that respiratory rate only increases quite late. And I encourage you to think of that next time you go for a run or whatever exercise that you do, that you first of all increase your tidal volume and then your respiratory rate. So in a non-intubated patient, you're looking at on the ward and you're looking at your criteria for code blue or met response or whatever you call it in your hospital. The respiratory rate is actually quite a late sign of an issue. Next slide. So in these patients, whilst the alveolar oxygen tension patients had a normal AA gradient, these have an increased AA gradient. They tend to have a low normal CO2 because rather than a high CO2 because they're hyperventilating. They tend to be very responsive to oxygen. So remember the delta P bit in that equation. If you increase the partial pressure gradient, i.e. give a higher partial pressure of oxygen by increasing your FiO2, they will respond accordingly. And the thing that I think clinically is quite helpful as well with this group is that they tend to, or they may often have fairly normal radiology. They're the PJP pneumonias are the ones I think of. You look at their X-ray and it's not that bad, but they're severely hypoxemic. And so if you have that in combination with this increased AA gradient and a lowish CO2, then this is the mechanism that I'm thinking of. We move to the next slide, thanks. This is the one we're probably most familiar with, and the VQ mismatch, which, and on the left there we have the West zones, so understanding that there is a normal variation physiologically as well, and then there are extremes of this. So the extreme of ventilation but no perfusion would be dead space, and the extreme of perfusion but no ventilation would be shunt. And yeah, as I say, we in health, we have a degree of spectrum. We're on a spectrum of this, and different alveoli will be on different parts of the spectrum. Now, I've put dead space in brackets here because, in all honesty, it isn't really a cause of hypoxemia. It's just really on this spectrum that I'm talking about. There's the dead space equation there, which is much more helpful for us nowadays to think of it in terms of the ventilatory ratio, in particular for ventilated patients when you're wondering if you're over distending and you've made your high PEEP has led to a lot of zone 1, a lot of over distension, using things like the ventilatory ratio that Pratik Sinha came up with is super helpful. What is probably easier or more readily noticeable at the bedside for dead space, however, is this PaCO2 end-tidal CO2 gap. The other thing that you'll also see is that the PaCO2 doesn't change proportionally to the change in minute ventilation. And causes of this are usually things like overdistension and low cardiac output. Now, I did say that, that there isn't really much hypoxemia with dead space, and I'm sure many of you can think of fairly submassive PEs that you've looked after that weren't that hypoxemic. And when patients with big PEs do tend to get hypoxemic, it actually isn't because of their dead space. It's more to do with cardiac effects or increasing blood flow through shunted lung regions. So moving on to shunt, which is actually probably the main pathology that we deal with for most of our patients. So we have the shunt equation there, which would necessitate a pulmonary artery catheter, essentially that most of us don't use routinely, so it becomes very difficult to use it in clinical practice if you don't have a pulmonary artery catheter. You need your mixed venous gases, you need your arterial gases, and you need to calculate your capillary oxygen content. The thing that's very special about shunt, say compared to the diffusion limitation, is that it responds very poorly to increases in FiO2. You tend to have fairly obvious changes radiologically. And the common causes that we see most commonly in our practice would be consolidation, atelectasis, aspiration, etc., as you can see there. Next slide. Oh, next slide, that's fine. That's just demonstrating the ventilator ratio. So in my last category for causes of hypoxemia, probably the two things, so if I've excluded or I thought about all of those things, I'm not convinced that any of those things are the cause of hypoxemia in my patient, I will be thinking about intracardiac shunt. I think if you hit next, Kathy, we'll play a little video. So this is a bicaval transesophageal echo view. And this is of a bubble study. So you agitate saline and you get these tiny microscopic bubbles, and you inject that ideally into a central venous, or a peripheral cannula is also fine. And you have a good image, someone doing a good image of the left ventricle. You shouldn't see any bubbles. They should all be absorbed and dissolved in the lungs that goes through the pulmonary circulation. If you see bubbles, I mean, people estimate within 3 beats, then that is very rapid entry of bubbles into the LV, then that's suggestive of an intracardiac shunt. And some studies think they can quantify the degree of shunt by the number of bubbles. So if you see 1 or 2, obviously your shunt is going to be smaller than if you see a massive stream of bubbles. If you see bubbles after about cycle 5, roughly, then that may be an intrapulmonary shunt. But just in terms of, you're not going from right to left in the heart, you're going from right to around the lungs and then back into the left. And obviously, because it's not being absorbed by the lungs, it is it's coming back through into the left side of the heart. The other thing to think about in this category is high oxygen extraction. So if you've got a really high metabolic demand, your mixed venous oxygen super low because you're extracting high amounts of oxygen, you've got a high cardiac output, so you've got a really low transit time of blood through your pulmonary circulation. That is another reason that could cause hypoxemia. Those patients tend to be fairly obvious in how they present. Next slide. So this is the quick sort of overview summary and sort of things that stand out that help sort of assess your patient, the patient you've been asked to see, because on 15 litres non-rebreathe. One thing I find super helpful is responsiveness to oxygen. If I go down on the FI, and I've had, I remember being referred a patient with who was on 10 litres or 12 litres of oxygen with SATs of 90, and I went down to 2 litres per minute of oxygen and their SATs didn't budge, nothing changed. So that sort of test of responsiveness to oxygen is super useful. If you're concerned that there may be an issue with hypoventilation, the AA gradient's again helpful. You can think about what you're expecting the CO2 response to be, and if you're really sort of stuck even with these things, then don't forget to think about your other causes. Next slide. Okay, so this is my reminder to say that a lot of what I'm going to be talking about now is about supportive management of patients with acute hypoxemic respiratory failure. But of course, it's absolutely essential to find out the pathology and get the diagnosis and give focused treatment. So we're now going to be talking about supportive management. Next slide. So acute hypoxemic respiratory failure, so I've talked about the different types. I haven't actually really defined it yet. So it obviously needs to be of a fairly acute onset, so within hours to days. It's hypoxemia is defined as a PaO2 of less than 60, so a 60 on room air or SATs of 90. And if you're savvy with maths, you'll probably work out that 60 divided by 0.21, i.e. room air, is roughly about 300. So PF of less than 300. Or more recently, we can also now use SF ratios, and the threshold there would be 315. And that's caveated by obviously having a good SATs trace and a SpO2 that is 97 or less. It tends to be, it has to be more of an oxygenation problem than a ventilation problem. We're talking about type 1 respiratory failure, not type 2. And ARDS really is like a subset of acute hypoxemic respiratory failure. So it's a little bit more specific, but there's a lot of common themes there in terms of oxygenation, in terms of acuteness of onset. But this is not due to a single pathology. It's ARDS is always secondary to something. So it's got this bilateral opacities, and now imaging in the latest global definition, you can use ultrasound or CT or X-ray. And you don't need, and they've obviously widened it in terms of requirements for being able to make the diagnosis, whether you're on high flow or NIV, or if you're in a low resource setting, no oxygen at all. Next. So practical, obviously is a platform trial looking at acute hypoxemic respiratory failure, and in their master protocol, this is how they've defined acute hypoxemic respiratory failure. So new or worsening respiratory symptoms within 2 weeks of oxygen support and oxygen therapy for at least 4 hours, defined as this. I won't read it out, you can read it. Next, I think it's really important actually that that acute hypoxemic respiratory failure is the overarching enrollment criteria for practical, because we are not good at recognizing ARDS. So LungSafe found that our recognition was somewhere, depending on whether it's mild, moderate, or severe, between 50 to 80%. Neil Ferguson did a study where at post-mortem, if there was diffuse alveolar damage and it was consistent, a pattern consistent with ARDS, we'd go back to look in the notes to see if ARDS was even mentioned, and that was only corresponded like less than 50% of the time. With ARDS, also the definitions change, and then how we apply clinical trials when the definitions change becomes a bit more complicated. And clinically, we often wonder whether making the official diagnosis of ARDS is really necessary outside of a research setting. Like, does it really matter in the terms that many of the interventions that have shown benefit in ARDS, like for example, low tidal volume ventilation, have been shown to be beneficial in all ventilated patients? So why do we need to specifically know it? So practical in casting this really nice wide net allows for focus in on specific subgroups like ARDS, but it also allows further breadth. Next slide. So you're all familiar with mild, moderate, and severe. PF ratios are 300, 200, and 100, and this is just to really highlight that, like, once again, that shunt doesn't really respond very well to increases in FiO2, and the more shunt you have, the less of a response you can have to increase in FiO2. I used to be able to, turn the FiO2 down, and magically I've improved a patient's PF ratio and feel like, oh, we've done a good job here with the patients getting better. So the few things just to say about this is, first of all, many trials require some sort of standardized assessment. So for example, in the ART trial, PF ratio was done on FiO2 of 100, I put the patient on 100%. And some trials specify after a period of optimization, so a few hours of stability and appropriate PEEP setting and appropriate titration of oxygenation. And then finally, I just want to say, beware of using it to define response. So whilst it's useful and informative early on, many trials have shown us that improvements or not improvements in PF ratio do not really guide outcome modification from interventions, and I'll come back to that bit later. Next. Yes, this is an interesting, very interesting study by Britos that looked at by strata of, so a collection of ARDSNet trials. If you divide them into tertiles by PF ratio and looked at mortality outcomes, but then you divided them by FiO2, that if you had and this, I think, again, sings to the fact that PF ratio is FiO2 dependent. If you had a higher FiO2 and a lower severity of ARDS by PF ratio, your mortality was actually higher than if you had severe ARDS by PF ratio, but were receiving a low FiO2. Next. So I'm not going to talk about non-invasive ventilation because it's been so well covered by Bruno, and high flow. So I thought I would take up from when to intubate a patient. And the answer is obviously that we don't know. There are no prospective randomized controlled trials, and I ask you to ask yourself whether you would be happy to do that. But in this this lovely international survey of people's thresholds to intubate patients, and it was done by cases, and it was very clever design so that you'd get a set of cases that all be slightly uniquely different, and then this clever analysis by Chris Yarnell allowed to pull out what factors were the factors that were really modifying people's decision to intubate. And as you can see by my arrows, the four main things were oxygen saturation, fraction of inspired oxygen, level of consciousness, and the breathing pattern, which if you use the Hackor score for NIV, it's sort of like almost as alluding to that, those sort of those elements. Next slide. So non-invasive goals of invasive mechanical ventilation to maintain adequate gas exchange, reduce work of breathing. We now also have an additional task, which is to prevent ventilator-induced lung injury. And I'm sure you're all familiar with the terms barotrauma, volutrauma, atelectotrauma, which is cyclic opening and closing of alveoli, biotrauma, and maybe not so much chronotrauma, which is a more recent concept, which refers to either the impact of respiratory rate or the impact of duration of any of the above. In terms of evidence base for lung protective ventilation, things that I think we have fairly robust evidence for that's well embedded is this tidal volume of 6 mils per kilo predicted body weight and a plateau pressure of equal to or less than 30. Next slide. So AHRF, one of our few trials that showed a mortality benefit with and this was the 12 versus 6 mils per kilo predicted body weight. Next slide. It's not. And you can ask yourself at the time, like, why did they pick tidal volume, right? Because barotrauma, I mean, maybe pressure would have been a better thing. And that came, the idea really sort of came from this physiological trial by Dreyfus and colleagues that looked at, what is more important, volume or pressure? And compared to controls, from memory, I think it was a rat model of low volume, low pressure. They used a high pressure, high volume, low pressure, high volume, high pressure, low volume, and looked at different markers of lung injury. So we have extravascular water, we have dry lung weight, and we have albumin concentration in alveolar fluid. And they found in this study that the low tidal volume was the thing that seemed to be more protective. As you can see, the third column is the lowest across all of these. But if you think about how this trial was done, so high volumes, high pressures, that's fairly straightforward. But how do you generate a high volume with a low pressure? And the way they did this was to use negative pressure ventilation. And if you use negative pressure ventilation, the alveolar pressures are low, but the transpulmonary pressures are actually quite high. And then if you think about how do you generate high pressure, low volume, the way they did that was to strap the chests. And therefore, again, whilst airway pressure may be high, your transpulmonary or pleural pressure is also high, so your transpulmonary pressure is low. Next slide. So this, of course, led to the very well-known Amato analysis in NEDGEM, which showed that it is actually driving pressure that seems to be the main mediator of outcome and survival. So if driving pressure increased, mortality increased. If you increased PEEP and therefore you also increased your plateau pressure, mortality didn't change. If you increased PEEP but driving pressure reduced, mortality reduced for a given plateau pressure. This came to this magic number of 16 that we're very familiar with. So aiming for a driving pressure of less than 16 seemed to really mitigate the risk of death. And really for every drop, whilst this is sort of this threshold value, every 1 centimetre of water below that has got an additional gain. Next. So, I mean, Ewan Gallagher did a further analysis of this, looking at respiratory system elastance. But what essentially driving pressure does is it normalizes the tidal volume to your lung volume. Because if you look at many of the lungs that we look after, they're not actually necessarily poorly compliant. There is just little available lung. So your 6 mils per kilo may be completely that's based on the fact that an assumption that your entirety of your lung volume is available. So if actually far less, only half of your lung volume is available because of atelectasis and collapse, delivering 6 mils per kilo is far too much and will over-distend and injure that baby lung. So what driving pressure essentially does is it normalizes the tidal volume you're giving to respiratory system compliance and thereby ultimately your end expiratory lung volume. Next slide. I'm not going to talk too much about mechanical power, but mechanical power is this idea that injury to the lung, that energy delivered to the lung is what causes injury. And that seems to be fairly intuitive when we think of demolition and injury and damage in any shape or form. And taking into account all the factors that lead to energy being delivered to the lung, so tidal volume and PEEP and respiratory rate and all of these things, you can come up with a very complicated equation called that allows you to compute mechanical power, and that was shown to be on retrospective analyses important for outcome. However, I just wanted to draw your attention to, I didn't want to go into too much detail, but this lovely paper by Eduardo Costa, who tried to look at all the individual components of mechanical power to see which ones are the most important. If you can only modify a few, or there's only, which ones are the ones that was worth spending your time on. And what I hope you can see here is that the two that are by far the most important is driving pressure and respiratory rate. And you'll see there tidal volume, which is on the far right, at the top on the far right, really on its own, no effect. So the other thing to point out is in the forest plot is driving pressure has a far greater effect than respiratory rate. And so he came up with this model where you could, a simplified version of mechanical power was 4 times driving pressure plus respiratory rate. And that, as you'll see again towards the bottom there of that forest plot, performed as if not better than mechanical power. And the way this is helpful for me at the bedside is to think of, I absolutely want to reduce driving pressure, and once I'm below 16 and I'm in that safe threshold, I know that every unit decrease is helpful, but at what cost in terms of respiratory rate? So if I can reduce the driving pressure by 1 versus the respiratory rate by 4, and it helps me sort of fine tune that aspect in a sort of a more simple way at the bedside. Next slide. So PEEP, in terms of setting PEEP, there are many ways, as you all know, and I'm not here to tell you which is the right way because we still don't know. Nothing really in any prospective randomized controlled trial has been shown to be superior than the low PEEP FiO2 table, and I know that many institutions use that as a default, certainly at baseline. I've just been telling you about how important driving pressure is, so maybe another way of setting PEEP is to set PEEP based on best compliance. Because you're ultimately aiming for a plateau pressure of less than 30, if you're not a believer in driving pressure, for example, but you want an open lung approach, maybe you set the highest PEEP that you can with a safe tidal volume that gives you a plateau pressure of less than 30. Your focus may be on oxygenation, and you do a decremental PEEP trial and you're looking at oxygenation. There are plenty of things you can do on a ventilator. So you can look at the inflection point on a PV loop that's there on the right. You can do an airway opening pressure maneuver, so a really slow inflation, and set PEEP 2 centimeters above that. I'm not going to talk about the recruitment to inflation ratio because I don't think I'm going to have time to do that. And I'm also not going to talk about the stress index, but that's sort of demonstrated just there at the bottom, but I'll maybe come back to that later if we have time. Next slide. Fancier things are EIT, so again a decremental PEEP trial where you're balancing over distension, looking at the crossing point where you're balancing over distension versus collapse. So looking pixel by pixel, how many units are now over descended versus how many have become collapsed, and finding that sort of like compromise at that midpoint. Esophageal manometry also not available in every centre, but a common way to set PEEP, particularly helpful maybe in obese patients where there's a high pleural pressure from abdominal, the weight of the abdomen and the weight of the chest wall, and maybe a plateau pressure of 30 is is too constrained, maybe it'd be safer to be higher, and to really understand how to set best PEEP in those, maybe just aiming for a positive transpulmonary pressure at end expiration is a helpful way, and particularly in those patients. Ultrasounds increasingly be used for more and more things, and you can assess recruitment. So using ultrasound, but notably you can't comment on over-distension easily as far as I'm aware. So there are some limitations with that as a strategy. Next. So I really like this paper by D'Souza and colleagues. And so if you're just sort of thinking, well, I've got all of these, which ones, how do they fit relative to each other? So if you have diffuse bilateral lung injury, you'll find that a PEEP strategy that was guided by transpulmonary pressure will be slightly lower than that guided by EIT, which is slightly less still than that guided by compliance. In fact, I think EIT, optimal PEEP by EIT, tends to sit roughly 2 centimeters of water above transpulmonary pressure. You'll see that this differs slightly if there is asymmetrical or unilateral lung injury in terms of how optimal PEEP would be defined by these methods. Next slide. I'm just going to spend just a minute on this because I find this interesting as well, and maybe not so well known about, is we've talked about like a lot of physiology, but there's also radiological phenotypes. Piaset and colleagues essentially divided ARDS into 3 categories, which was lobar, diffuse, and patchy, and over a series of experiments found that if you had a diffuse disease, maybe you were a better responder to high PEEP, and if you were non-diffuse, so either patchy or lobar, then you wouldn't respond as well to high PEEP, but you're maybe perhaps more likely to respond to prone positioning. Next slide. I love the live trial, which we looked at a personalized PEEP strategy based on radiological phenotype. This was a lovely trial that randomized patients to either conventional care or a personalized PEEP strategy. And if you got the personalized PEEP strategy, whether you were diffuse or focal, if you were diffuse, you would get a high PEEP strategy, and if you were more focal, you would get a low PEEP but early proning strategy. And what they found in this trial, that there was no difference. If you looked at the per protocol analysis, so correctly identified patients getting the correct treatment, there was a benefit with personalized PEEP strategy. But if you were misidentified, so if you were called diffuse when you weren't and you were given high PEEP, there was an increased risk of harm. So what they essentially found is that we're not very good at phenotyping radiologically, and there's some ongoing nice work in this field using other tools to do a similar thing. Next slide. So in summary, for PEEP, for me, that high PEEP can be beneficial, but you need to have recruitable lungs, so alveoli full of pus are not recruitable. I didn't go through it, but there's several 3 big negative trials looking at high versus low PEEP strategies. But in a meta-analysis of these, there was found to be beneficial of a high PEEP strategy in more severe disease, i.e. PF ratio of less than 150. So I keep that in mind. I'm not talking about biological phenotypes, but hyperinflammatory phenotypes possibly respond better to high PEEP as well. And as I just showed you, sort of radiologically, if you have diffuse disease, you may respond better to a higher PEEP strategy. So they're just things that I keep in my mind when I'm thinking about that. Next slide. So how to actually implement that, I don't know. There's no real strategies to guide you. I think it depends a bit on what you have available as well. So if you're severe, your PF ratio is less than 150, maybe consider starting with a higher PEEP strategy. And when you first put someone on a ventilator, thinking about maybe using a higher PEEP FiO2 table, and then really personalizing it based on what equipment you have, what skills you have, and what your priorities are. So if you're particularly worried about lung protection, and you maybe have more of a focus on respiratory mechanics, if you don't have EIT or esophageal manometry, or if you're really worried about the patient's RV, you may be thinking more about gas exchange and optimizing oxygenation and ventilatory ratio, and that might be your priority. Next slide. Proceva. I'm not going to go into any detail here, really. Everyone's very familiar with this. Prone positioning is important. It works. There are very few actual contraindications. open abdomen and unstable cervical spinal injuries. But even if you've got things like raised intracranial pressure, it's a balance, isn't it? If you're severely hypoxemic and you've got a raised ICP, you've got to balance. Maybe improving oxygenation will help. So as long as you've got some sort of monitor, you might try it and then just say, well, you'll just call it if it's making things worse. There are quite clear indications for discontinuing prone positioning, and I just want to reiterate here that the mortality benefit from prone positioning was not related to the oxygenation benefit. So when people say patients are not a prone responder because their oxygenation didn't get better, that doesn't necessarily mean they're not going to get a benefit, and proning should continue until either the criteria are met or there's important contraindications develop. Next slide. So just back to this responsiveness thing I mentioned before about the PF ratio and how you shouldn't really use it as a responsiveness for your targets. I've just mentioned just now that Prosiva showed the mortality benefit was unrelated to the oxygenation benefit. In ARMOR, the low tidal volumes of the 6 mils per kilo actually had worse oxygenation than the 12 mils per kilo. So if you looked at improvements in oxygenation, you would go for 12 mils per kilo based on that, but that didn't lead to a mortality benefit. Importantly, also, nitric oxide has been shown in many trials to improve oxygenation, but not to confer a benefit in terms of clinical outcomes. So we don't do that. So just to really sort of like make you think, what is your measurable outcome? And just because you're not seeing what you think is a response in terms, especially in terms of oxygenation, that shouldn't drive your management decisions alone. So hypoxemia is not the major modality for mortality in acute hypoxemic respiratory failure in ARDS, and I'll come back to that. Next. In terms of neuromuscular blockers, the idea is to prevent injuriously large or desynchronous efforts, to protect against derecruitment. So when we think about increased drive and effort, we also often engage our expiratory muscles, and we may reduce end expiratory lung volume, and reducing oxygen consumption by things like your respiratory muscles. Now, as you all know, Acute showed a benefit with neuromuscular blockers, and then some 10 years later, a very similar trial showed no benefit at all in terms of mortality. However, it's important to note in these trials that the control group changed significantly, with Acute being a deep sedation versus deep sedation plus neuromuscular blocker, with higher incidences of pneumothoraces, and I thought that deep sedation may have been leading to reverse triggering in the control arm. And in the ROSE trial in 2019, the new standard of care was a higher PEEP, lower sedation strategy, and that maybe therefore the benefit of neuromuscular blocker was mitigated. Next slide. So because the guidelines don't really clearly how to tell you how to implement this. This is sort of just my I guess my practice in terms of how I think of it. I think of it in severe ARDS for sure, especially if the patient's hypoxemic with that. I'm calling for ECMO and things. I'm making sure that I've tried this. If they've got moderate to severe ARDS, so less than 150, and they've got any indication for deep sedation, say they've got ventilated asynchrony, or they've got large respiratory efforts, and I think they're at risk of PCILI, and I've got like GCS3 and I'm on 4 agents, and I'm just making them more hypotensive, needing more vasopressors and more fluids, and I've got a higher risk of reverse triggering, and just paralyze them at that point. And then finally, if the severely impaired respiratory mechanics, I not infrequently will just give a bolus just to see if it's beneficial and if it helps. And if it doesn't, then I obviously don't continue an infusion, but I might if I'm really struggling otherwise to achieve lung protective ventilation and safe driving pressures. Next slide. So, I mean, ventilation causes a lot of problems, right? We talked about putting on the ventilator, and then we get this, ventilation, positive pressure predominantly ventilates the non-dependent lung regions. We get atelectasis and collapse of the dependent lung regions. And then we're trying to do all these things to keep the lung open with high PEEP, and then we're having to prone them. And we cause all of this trouble. Whereas if we keep the diaphragm active, in this lovely study by Hedden-Stierna and colleagues, where positive pressure plus diaphragm neurostimulation as a physiological way to just see what would happen if the diaphragm was active, markedly reduced atelectasis in the dorsal lung regions. Next slide. Positive pressure also causes hemodynamic dysfunction or cardiac dysfunction. Most of our patients are preload dependent. Well, not most of them, unless you work in a cardiac unit, are not going to get the benefit from LV afterload. They mostly come in preload dependent conditions. We reduce venous return, we reduce cardiac output. Again, we give fluid and vasopressors, cause end organ congestion and arrhythmias. Furthermore, there is an impact on the right ventricle, so pulmonary vascular resistance is increased with both atelectasis and collapse and overdistension. And that can, our poor little RV that is thin and isn't used to accommodating high afterload pressures dilates. We then get high diastolic filling pressures. The tricuspid valve increases its regurgitation. We get congestion of our tissues, and this is how we get RV dysfunction and cor pulmonale, and essentially congestion and multi-organ dysfunction. Next. So the other thing that ventilation does is it, by unloading, if we overly unload the diaphragm, that can lead to weakness and ICU-acquired weakness. If you're using that as your marker of diaphragm function, will miss diaphragm dysfunction half of the time because it's twice as common. The diaphragm atrophy is 8 times faster than your other muscles, roughly. And in this lovely study by Idunn, within sort of 3 to 4 days of mechanical ventilation, this is all comers, this is not ARDS, 50% of patients had a rapid atrophy, diaphragm atrophy. A small proportion had an increase in diaphragm thickness from baseline, but notably, both increases and decreases in thickness from baseline were associated with adverse outcomes. Next, sorry. So diaphragm effort seems to mediate this. So if you had a normal diaphragm activity and diaphragmatic effort in terms of a thickening fraction of 25 to 40%, your diaphragm thickness stayed the same. If you had high levels of effort, your diaphragm thickness would increase, and it's too rapid for that to be hypertrophy. It's probably going to be inflammation and edema. And so if your diaphragm's doing nothing, it would rapidly atrophy. And both those extreme changes lead to a reduced likelihood of liberation from the ventilator. Sorry, next slide. So this is a problem with letting patients just transition to spontaneous breathing early to try and mitigate some of the harms of positive pressure ventilation and ventilator-induced lung injury, is they tend to transition from like a low drive to a high drive. And they can cause injurious lung injury from this lovely study by Mascheroni and colleagues who injected salicylate into the cisterna magna to induce hyperventilation, found significant reduction in lung function over time. And Yoshida and colleagues, if you hit next, nicely describe this phenomenon of Penderluft, which is with large diaphragmatic contractions, your sort of your ventilation to your dorsal lung regions is sucking out air from your anterior lung regions. And you've got this sort of movement or Penderluft effect of deoxygenated gas being moved and overextending and then collapsing these alveolar lung regions. You can see there that the ventilation to the dorsal lung region is 91%, with the anterior lung region of 9%. And this patient was taking very large efforts. Next slide. Yoshida and colleagues also importantly found, though, actually the risk of lung injury from patient self-inflicted lung injury is dependent on your baseline lung injury. So if you had mild lung injury, the risk of injury was small, but if you had severe lung injury, obviously inflammation, edema, high drive, high effort, you're going to cause more injury by spontaneously breathing. Next slide. I'm going to skip over this actually, if that's okay. Next slide. Just to say that drive and effort are probably very important for outcome, and certainly prospective observational and retrospective studies. It is very difficult to control drive and effort, though. This lovely study by Jose Dianti, even after optimally titrating sedation and ventilation, so PEEP and pressure support, it was very difficult to get patients to meet lung and diaphragm protective targets, and they often needed either partial neuromuscular blockade, or if you were on ECMO, a titration of your sweep gas flow was also very effective. Next slide. So we're trying to find this balance. We don't want to cause ventilator-induced lung injury, We don't want to cause patients self-inflicting lung injury, and it's really hard to know how to balance that. There's also the impact of the diaphragm of both of these extremes, and we've also touched on some hemodynamics. Next. So when to transition to spontaneous breathing? That is a question that I'm glad to say there's been a lot of work being done and is ongoing in this area. We don't know. This lovely target trial emulation from the WeenSafe database looked at early versus delayed transitioning, which they've defined based on oxygenation, so PF ratio, and obviously not being on a neuromuscular blocker. And they showed improved outcomes in the early weaning cohort. However, you know, there's as I said, there's a lot of work to be done on this. There's other studies that have shown other factors may be important, such as inflammatory profiles can also maybe predict effect. Next slide. So I have touched on this earlier, actually, before I intended to, which is talk about the importance of the right ventricle and the effect of RV dysfunction and cor pulmonale, which is really the main mediator of mortality in acute hypoxemic respiratory failure and ARDS, and in terms of congestion of end organs because of that. This lovely study by Desap and colleagues found that your RV is at risk if you've got 2 or more of these things, and I have these in my mind when I think of who should I be echoing, who should I be monitoring the RV, which is a pneumonia as a cause of ARDS, a PaCO2 of more than 48, PF of less than 150, or driving pressure of 18 or more. And in those patients, they need some sort of assessment of the RV, and or if they've got other reasons to have an at-risk RV. So for example, they've got OSA or OHS, obese, or already a pre-existing known RV dysfunction, because that will modify how you prioritize certain things like airway pressure management. So that, for example, if you had no tools available to you and no method of serially monitoring the RV, you didn't have a pulmonary artery catheter, you weren't confident with serial echoes, then one study suggested that if you change your plateau pressure threshold from 30 down to, I think it's 26 or 27, that is RV protective. You also may influence your fluid strategy, which I haven't talked too much. It may influence your permissive hypercapnia that I also haven't mentioned. But I know that you're all well aware of in terms of lung protection. And this is the group where inspired nitric does have a role and could be beneficial. So not for improving hypoxemia, but if you've got RV dysfunction, protecting the RV, reducing the RV afterload through improving VQ matching here is beneficial. Next slide. So in terms of the practical platform, I am finishing now, you'll be glad to hear. In the IMV domain, there is the lung protective ventilation, which is 6 mils per kilo, versus driving pressure limited strategy, which I'm glad to say has got takes into consideration both passive and spontaneous breathing. So passive less than 16, and spontaneous it's got a clear strategy for when you transition to spontaneous breathing in terms of monitoring effort and dynamic transpulmonary driving pressure using POC in that arm. And then there's also a lung and diaphragm protective ventilation arm in this particular study. There is a study looking into EIT. This is currently in a sort of a feasibility, I think, phase 2 trial, looking at EIT-based ventilation strategies, which is exciting. Within the ECLS domain, there is expand ECLS. I haven't talked about ECMO at all and indications for referral. There's been very well covered by Eddie and Neil in other talks. But I think expand ECLS is really interesting and exciting. It looks at, rather than just having gas exchange, like the Eolia criteria of oxygenation and CO2, targets for ECMO criteria that may be like severe respiratory mechanics, so issues with severely poor compliance or something should be an indication for ECLS. And IMV ECLS is looking really about how we ventilate patients when they're on ECMO, because we know very little about how to do that. Next. This is just another plug for, I think for me personally, probably the most important trial of the decade, which is the driving pressure versus lung protective ventilation trial. And there's just just outlining some of the two arms there. Next. So this is my personal perspective. So physiology is helpful for sort of physiological phenotyping. Again, absolutely essential to identify and treat the underlying cause. I personally, and this is a personal opinion, think that physiological phenotype should drive the ventilation strategy. So things like plateau pressures maybe should be modified based on obesity or RV dysfunction. Things like your respiratory rate based on your pH, you might need to modify again based on your RV. Importantly, the tidal volume, 6 mils per kilo, may not be lung protective enough, and I might modify that into the 4 to 8 range depending on the driving pressure. Just to say that obviously is not prospective randomized controlled trial evidence-based and guideline incorporated, but within the realms of usual practice, that's how I sort of like modify that range of 4 to 8 in patients. In terms of a higher PEEP, I think about it if they've got imaging that suggests that they've got recruitable lung, if they're more on the moderate severe end of the spectrum, if they have a diffuse kind of phenotype on their radiology. And in terms of how you choose PEEP, I recommend that you think about what tools you have available, what experience, and again, what priorities you have for your patients. I would love, and I don't think there is currently a trial looking at prone positioning for respiratory mechanics. Again, sort of moving beyond the oxygenation target. So maybe there's a in the future something to expand on our practice there. We've talked about neuromuscular blockers, and again, I've talked about how I use them in terms of severe hypoxic respiratory failure with hypoxemia, or if there's issues with patient-ventilator asynchrony and PCILI requiring deep sedation, or in patients with severely impaired respiratory mechanics. I haven't touched on oxygen targets. That could be a whole talk in itself, but obviously we know that both hyperoxemia and hypoxemia and the extremes of those are harmful, and we're trying to sort of work out at the moment where in the middle ground may be the best place to sit. In terms of transitioning to spontaneous breathing, there's a lot of work to be done here. This is exciting. Maybe upon resolution, but I don't know how we define resolution in this group either. And then I think biological phenotype should be what drives pharmacological agents. So your statins, your baricitinib, and your steroids, I think probably driven more by biological phenotype than anything else. Next. That might be the last slide. All right, thank you. And sorry for going over.
Okay. Thank you, Idunn, for the excellent presentation, despite the slightly bumpy start. But we are behind schedule, but we'll now open the floor for if someone have any questions. Well, I think while people are thinking of questions, I start with one. Do you think that it's time to move beyond the traditional ARDS definition for clinical trials and instead focus on patients with acute hypoxemic respiratory failure, regardless of whether they meet ARDS criteria?
Yeah, I mean, I think certainly from a ventilation trials and physiology point of view, I really do think we're bad at diagnosing ARDS at the bedside. It doesn't massively impact what we do in terms of lung protective ventilation is beneficial to everybody. And ARDS, the definition keeps changing somewhat, and then you're applying the outcomes of trials that were based on slightly different patient cohorts, and you're trying to juggle all of those things. I've had discussions with people about whether or not there'll be another ARDS definition at any point, and whether we're actually going to rather move towards phenotyping and biological phenotypes and then physiological phenotypes, and move away from something that is both vague and hard to pin down, but also difficult clinically to use. So yeah, no, I'm very glad that Practical is using acute hypoxemic respiratory failure. It's far more clinician friendly.